Thanks a lot, Ron. Thanks for that nice introduction. Thanks for inviting me here today. First off, I guess I should point out that in doing this presentation, Ann Harris is actually a postdoc with the Occupational Cancer Research Centre, who's really been leading this project, even though I'm the one presenting it here. So I'm going to direct questions to her later on. The Occupational Cancer Research Centre has a fairly broad mandate in terms of research, especially considering the size of the centre. We're still relatively small, certainly compared to the IWH. Many of you may know that we're actually really just one block away, so we're very close by. But one of our areas of focus is to develop surveillance of both occupational cancer and carcinogens, and certainly that has been a major focus of our group to develop. I've put down here, I'm going to give you a couple of the definitions, the kind of standard definitions for surveillance. And I realize that that's a bit of a review for many of you, but I've actually been surprised at times. I've actually even been at a symposium on surveillance where one of the senior cancer epidemiologists in the country didn't really have, I think, a clear idea of what surveillance is and how it is different from, let's say, standard epidemiology. I mean, this is one of the main, probably most widely quoted definitions of surveillance. This comes from the U.S. Centers for Disease Control. And I guess the important things that you see in most definitions are the issue that it's ongoing, systematic analysis and interpretation. But always in the definitions, you'll see the second part here, which is timely dissemination and a real focus in on really the fact that this is a public health activity. This is a prevention-related activity, and it differs from research that simply contributes to a body of knowledge. The idea is that this is very applied and you get information out quickly. This is from the Dictionary of Epidemiology, and of course then you see ongoing. One thing I actually like in this is, which is I think true but kind of differentiates it. Methods distinguished by their practicality, uniformity, and frequently their rapidity rather than their complete accuracy. The idea here is that surveillance gives us quick answers, but they're not necessarily, it's not like we're trying to replicate an entire epidemiologic study or put in the resources for that. It's to give us flexible tools to answer questions. Now, Canada is somewhat blessed in terms of basic cancer surveillance. We have both good mortality and cancer incidence. We have a series of tumor registries across the country. This is actually mortality mapped out by the different health regions in the country. But what surprises people sometimes is just how much cancer rates actually vary across the country. This is lung cancer, for instance, and you can see that even within provinces. I mean, people may know that Quebec has higher smoking rates than other parts of the country, but even within, let's say, Ontario, you see quite a bit of differences in cancer rates. And what explains these cancer rates? We have relatively little risk factor-based cancer surveillance that happens in Canada. It definitely is a gap. I apologize to folks who are way at the back because this is probably a little bit low, but you'll see here, for instance, that Lambton County is in the fairly, the high thing, and this is, there's a range, the high areas, the high health regions here have about a 50% increased risk of lung cancer compared to the low areas. So we do get lots of different, lots of variety of cancer rates across the country, and we don't always have ready explanations for why that happens. Ooh, I forgot to use my little thing. So why do we need occupational cancer surveillance? And I've listed here, some of the basic things. Certainly, when you look at the kind of, trying not to stand here in front of the screen, the basic things that you see here, common to all surveillance is monitoring patterns and trends. It's the ability to provide quick answers to policy relevant questions. You don't really, if somebody says, well, we hear that in France, this group is at a higher risk. Is that group at a higher risk here in Canada? People are sometimes amazed, members of the general public that I've talked to, that in fact we don't have that ability right now to answer that question, to simply say, well, here the hairdressers do have an increased risk of this cancer or that cancer. You need to launch a specific epidemiologic study to answer those questions with the current things, but we have the infrastructure to actually answer these things quite quickly once the systems and the platform is set. There are frequently new hypotheses that are coming up. People may remember when shift work was a fairly new thing on the map for occupational cancer. Well, the Nordic countries were able to launch very quickly a number of fairly simple studies using the infrastructure that they have to answer questions about shift work and cancer. Canada did not have that ability to do that at that time. Historically, when you look at occupational cancer and you look at how we've identified occupational carcinogens, very frequently in the past it was alert clinicians seeing unusual patterns amongst their patients coming in. So you might have a physician who is responsible for a community where a particular factory or hazard exists, and they notice an unusual number of cancers coming in. Sometimes it was alert workers organizations or the workers themselves who might say, hey, I've got 3 buddies that have this kind of cancer. But in this day and age, the relative risks that we're seeing frequently in new carcinogens are smaller. Oftentimes our workplaces are smaller, so you don't have, let's say, the population there to look at to say, well, I suddenly see, this increased risk. So the ability to kind of identify unexpected excesses of cancer is something that surveillance can provide. And it gives us the ability to kind of generate this kind of data relatively quickly, and that in turn gives us often the ammunition that we need to make the argument that we need a much better study to go more into depth on this. Now, how do we actually set up an occupational cancer surveillance program? I think that, probably not people in this room, but oftentimes people might think, well, we compensate those. But in fact, even though Ontario is probably one of the best places in Canada to be in terms of getting compensated for occupational cancer, we still only compensate about 1/10 perhaps of what is occupational cancer out there. So even though we're up to maybe 200, 250 per year that we're compensating, and these are fatal fatalities, we probably compensate more non-fatals as well, although this is largely driven by lung cancer and mesothelioma. But still, that's probably only, if we look at the current burden studies that are being done in similar industrialized countries, we might expect several thousand or anywhere from 2,000 to 2,500 cases of workplace cancer per year in terms of the actual burden. So this only gives us a partial picture. Very few, one of the challenges with cancer is that cancer does not look different depending upon what its cause is. You can't really tell from looking under a microscope or doing a test that something is a workplace cancer versus not. There are a few cancers, and very few that we might say are primarily or almost solely occupational. Mesothelioma is one of them, and here's a map of mesothelioma rates across the province. Here you see Lana again, which is one reason that I pointed out that it has a higher lung cancer rate. But in fact, even here we don't have a lot of, because we don't know what people's jobs were for many of these unless they happen to be a compensated case. Even then we're a bit hampered in terms of cancer surveillance. But there are very few examples of that. In Europe, for instance, they might consider cytonasal adenocarcinoma, so basically adenocarcinomas in the nasal passages, as being predominantly workplace. Burden studies in Europe would indicate that about 70% of those are due to wood dust or leather dust, and then additional cases might be due to other types of nasal carcinogens. But that's extremely rare cancer here. In Canada, we've tried to map that out in terms of of looking at things. Here you see kind of over time. So this is more traditional cancer surveillance, but breaking it out by the histologic type. This is all sinonasal cancers, rates dropping because of squamous cell carcinomas, which are related to cigarette smoking. There may also be occupational causes, but I think that's why we're seeing the drop here. And then you see adenocarcinomas. But examples like this, where looking at a subtype of cancer that we could say is occupational, are very, very rare. The great majority of occupational cancers wouldn't fall into that. There are a few chairs that people want. It's not going to disturb me if you readjust and sit in the chair. So the challenges of establishing an occupational cancer surveillance program, I mean, one of the major challenges, as I mentioned earlier, is that the clinical and pathological expression of cancers do not generally differentiate by cause. This is just a medical way of saying that they don't look any different under the microscope. So we don't have the ability to do that. Compensation records only capture a small percentage. A challenge is that our administrative health records in Canada, but also I'd say in almost all countries in the world, do not capture what people's jobs are. They don't capture where people work. But even if we start doing that now, which I think would be a great thing to do, the relevant time period for occupational exposures when it comes to cancer, for most cancers, is probably anywhere from 10 to 40 years in the past. So we've got a challenge there in that what we're really interested in, the relative period for now, is way in the past, so it's going to be hard to kind of fix that. Occupational cancer surveillance in North America has predominantly relied upon death certificates, both as a source of information on the cancers and as a source of information on occupations. And that's a pattern that we brought over from the UK. The Office of the Registrar General had been doing that for a long time. The first place in North America that was done was in Washington State, where the state epidemiologist, Sam Milham, back in the 1970s, got support from NIOSH in the United States to begin actually entering in occupation and industry on death certificates going back as far as 1950. Now, as a surveillance thing, he very quickly showed that you could see some of the things that are well-established occupational causes of death within this data set, and then began to identify unusual things, let's say cancer among aluminum smelter workers or other things that had not been adequately studied at that point. So based upon this, a number of states actually began coding their death certificates. And you know, the only province that I'm aware of that's done this, although I would happy to be corrected, but I haven't been able to find any place else, was the province of British Columbia, which is conveniently just north of Washington State. So we have a lot of communication between our two provinces. And there, the BC Cancer Agency got money from the Workers' Compensation Board of British Columbia, now called WorkSafe BC. They got a grant to actually code death certificates going again back to 1950. And I just gives a little example of something that could be pulled out from there. In the 1980s, wood dust and sinonasal cancer was at that time a fairly new issue in terms of North America, and so there's the ability to, let's say, look to see, but certainly is extremely rare cancer that even with records spanning here, this is 34 years of deaths in the province of British Columbia, we still only see very, very small numbers of cases, which, when you add them up, are much more than expected, but it makes it hard to draw conclusions. One of the hallmarks of this kind of research is the use of a thing called the proportionate mortality ratio. PMRs are not used often outside of occupational epidemiology. And even then, many people who are not involved in mortality statistics won't necessarily be familiar. It's based on a ratio of observed numbers of cancers to the number expected based upon the proportion of deaths that would be due to that particular cause among the general population. So it's a kind of an odd statistic in that proportionate mortality ratios, you can't do it for all causes of death because it's always one. So basically, what you have here is a bit of a seesaw in terms of proportionality. And it makes it kind of an odd thing to go to look at. So it kind of maybe works for some of the rare cancers, but let's say you have an occupational group where, because they're a healthy working population, they might have a lower risk of cardiovascular disease. If they have a lower proportion of people dying from cardiovascular disease for their age, that means all other causes are pumped up by that much. Or likewise, if they had a higher risk of lung cancer, the other ones would go down. So it makes it a little bit problematic to interpret at times. Although it is still interpretable and useful, I think it is still a challenge. Some places like the UK tried to overcome that and calculate SMRs by actually looking at observed numbers among working age people, so people aged 20 to 64, and then using census figures to say how many people were actually employed in those different groups. But that's a challenge because the data is coming from two different sources. And on death certificates, what's usually coded is the usual occupation and not necessarily the current occupation, although presumably among people who die of working age, you might get that. But many occupational cancers don't happen until after the age of 65. So that does represent a challenge for doing that. Now, that said, these systems had proved fairly useful, and in the United States, NIOSH actually created this National Occupational Mortality Surveillance System, and they actually took all of the states that are coding their death certificates. They have all the data available there, and you can query it, and so that if you want to look at any group in the United States that they have coded, you can actually pull up all their causes of death, and it's actually a fairly useful database. I don't think many people are actually aware of it in Canada, maybe not even in the United States, but I've actually found it quite interesting if you want to quickly see, well, if somebody asks, well, are steel workers generally at increased risk for a particular cancer? I don't know, I could go look and see whether people in the steel industry are. So it's a fairly useful database on that level. We certainly don't have anything like it here in Canada, but it is based upon that kind of death certificate-based data. Now this is, I don't know if they say it NOMS, but there is now a NOMS 2. A problem is that now it's dropped down and only 7 states still code their death certificates, where at one time it was about, I think it might have been up to 24 states or 27 states at one point were coding. Now it's really on the decline again. So this is the newer, more updated version of this. When they launch their second program, is going to have a smaller database to operate with. Still fairly substantial size of data. So using a system that's based just upon death certificates has a lot of issues associated with it. One is questions regarding the validity of the information on occupation and industry. Now, these questions probably arise less for something, let's say, like carpenters or even firefighters, people who go in and they have a career, physicians or dentists or nurses, people who go in and establish a career and they keep that same occupation for the majority of their working life. Those folks, it's probably pretty good. But let's say you were looking for a group of industrial workers or people who have a particular exposure or a particular circumstance. If it is a job, for instance, even within, let's say, our basic resource communities where you would expect some stability, still a person in a sawmill starts off in a cleaning job, and eventually maybe they end up being a saw filer. And so, but if you're interested in saw filers, you're not going to see it on these death certificates. So there are questions about the validity of the occupation and industry, also because people are putting in, they're supposed to put in the usual occupation. Sometimes what ends up getting on there is the current occupation, or sometimes if somebody is older, that attending physician may not even know what the person's occupation really was. So maybe there isn't somebody around to ask that question to. That raises challenges regarding what we can use this data for. In terms of cancer, oftentimes we're interested in a particular type of cancer, and the information can be quite limited on a death certificate. So it may say leukemia, but for those of us now who study leukemia, there's a difference between chronic lymphocytic leukemia and acute myelogenous leukemia. This is differentiation that you can make using tumor registry data, but you cannot, make much of a differentiation using death certificate data. Things like mesothelioma sometimes aren't accurately recorded. And then there are the cancers that people don't die from. So if you're interested in bladder cancer, most people don't die of bladder cancer. So you're going to be missing lots of cases in those ways. I've already mentioned the challenges regarding proportional mortality ratios. This is another challenge for using death certificate only based systems. Now, probably at the other end of the spectrum of surveillance, and I'm not checking for messages. This is my watch. Okay, just want to make sure I'm not taking too much time here. In terms of the other end of the spectrum of surveillance, you get something here like the National Enhanced Cancer Surveillance System that was set up by Health Canada. Later, the part that got cleaved off and put in the Public Health Agency of Canada, which will probably be cease to exist soon and be merged back into Health Canada. But this is probably a Cadillac version of what you might want. What they actually did was send out over a 3-year period. They, and I'm sorry for the small size of this. Actually, what I'll do is I'll go to this. So it was a collaborative project of Health Canada and provincial cancer registries from 8 different provinces. Over a 3-year period, they sent questionnaires and got information back from 21,000 cancer cases and kind of a range of different cancers. So some of the common cancers, and then they took only a sample of. Other ones they tried to collect, for instance, all of some of the rarer cancers. They focused in on people aged 20 to 76, and at the same time gave the questionnaire to 5,000 population controls. It wasn't the longest case control questionnaire. It was meant to be shorter, easier for a patient to actually fill out. But yet still it collected a full work history, residential history, a lot of these basic things that we would need to look at not only occupational cancer, but many different types of cancer, environmental cancer as well. The data collection, however, it doesn't really fit exactly our surveillance definition because it isn't really ongoing. I think the idea might have been at one point to kind of try to continue this on, but really collected 3 years of data. Nonetheless, this data set has proved, I think, very fruitful. It's taken a while, but I mean, there's, last time I checked, maybe 120 publications. I'm connected with 2 or 3 ongoing studies that are involved with it. So despite the fact that this is, let's say, a bit of an aging data set, it actually is being used for, to look at a lot of different questions, including occupational cancer. But in terms of things that might be ongoing, at least in this economic climate, you'd probably want something that would be a lot more, not extremely costly, something that might allow you to be ongoing in nature in your follow-up, but you'd also need a very big study. 20,000 cancer cases is big in terms of one case control study, but then split that up among all the different cancers, and you see that it's really not as big as you would want. And it doesn't give you the ability to look at a whole bunch of different questions in terms of if you want to focus in on, let's say, specific groups of people who might be exposed to carcinogens. The other model that has been used is to kind of link either census data or other large cohorts, and to link those in with either tumor registry or mortality data. At this point, it's been more common to do with mortality data, but certainly, and I'll show you what we have in a minute here. Cancer incidence data is possible. So, what you get then is something that kind of mimics a prospective study. You hope it's large, hopefully representative, but in fact, some of these studies have not been representative and still have led to the creation of a lot of new knowledge. So, for instance, the Cancer Prevention Study and the Cancer Prevention Study 2 that were done by the American Cancer Society were very, very large studies and have really fed into our knowledge of air pollution health effects. They were Cancer Society volunteers and their friends. Literally, they asked all their volunteers, join the study, recruit all your friends, and so that's not a very representative sample of the population. And yet, it is large enough and it allows internal analyses enough that you can actually still gain a lot of knowledge from it. The limitation from an occupational point of view is this, that occupation and industry might be reliably captured, but it's for a single point in time. But at least it is evenly collected, and it does give that slice in time. The challenge being also that it lacks information on potential confounders. Now, an example here for Canada is kind of a classic one, that there was a 10% sample of the Canadian labor force collected in 1965. They did annual surveys on them, through 71. They lost 1970 somehow. Nobody's ever explained to me what happened to a whole year's worth of data. But they basically have these annual surveys here, so that's kind of nice. It was about 700,000 people, and they did mortality follow-up through 1991 with 143,000 deaths. So this is deaths overall. Probably, I guess, a third of those are cancer deaths, but still a pretty substantial group. But the challenge here is that they then went on and made 28,000 comparisons that are specific occupation and cause of death combinations. So divide this by this, and you see that the numbers are not always that big, and that there are challenges then in size. Nonetheless, this was a great effort, but it didn't really produce as much as one would hope. This CD, I think, is still available from StatsCan. I mean, I've got one, but I don't know, maybe Cam has one.
We have one here, too.
Yeah, so there's not a lot of these available. It didn't make a lot of the dissemination. You don't see dozens of publications. You see about a half a dozen ones that are mostly methodological in nature. It was a good exercise, but it was really still a one-time exercise. But nonetheless, it is one of our few good examples of this. Now, a good example, I think, of where we could go with record linkage is provided by the Nordic Occupational Cancer Study. This is a surveillance-level study that was conducted in the Nordic countries, and it's a collaborative thing of all 5 Nordic countries and all of their tumor registries, and it connected their 1961, 71, 81, and 91 censuses into all of the tumor registry data that they have there. Now, the Nordic countries have national tumor registration coverage, a club that is a relatively small club in the world that Canada belongs to as well, although in our case it's a series of provincial cancer registries. They have a particular advantage in that I believe all the Nordic countries, but at least most of them, have a single identification number that might be like our social insurance number, but it's actually used for everything. That means record linkage on a deterministic basis is very easy in the Nordic countries compared to here, where we're often using probabilistic methods because we don't have a single universal identification number. So that presents a challenge here. This study is really quite big, and so it has all these different collaborating agencies in each of the provinces, but it has 15 million participants aged 30 to 64 from these 5 countries, and 45 years of follow-up, and 1.4 million cancer cases. So this is kind of a Cadillac version of a record linkage surveillance study, record linkage only surveillance study. Now, recently they contacted me because they asked me to help. They're trying to analyze their data. They've produced this kind of mega report, and I encourage people to go to their website because you can actually pull out tables for specific occupations that they've looked at and industries in a similar way that you can the NIOSH website. But now they want to go do some more in-depth analysis on groups that might be of interest, and one of those was firefighters. And because there are no researchers in their network of the Nordic countries, whenever they have a question, then they simply pull in somebody from elsewhere. I've done work on firefighters, so they pulled me in. These are fires in Vancouver, if you'll notice the mountains in the background. So this is an example of what they can do on firefighters. Firefighters aren't the most common occupation, but this is a surveillance study where you can see really the numbers of cancers that they could look at. Because of the nature of the database, they do not have proportional mortality ratios. They have standardized incidence ratios, which are much easier to interpret. And these are all, internal analyses that they've done. And these are sites that have been observed in other studies, but they did see some excesses here that kind of fit with those other studies. The magnitude of these relative risks is not huge, but that's kind of the nature of surveillance stuff. You're not going to see the bigger relative risks that you might see that if you did a full study and you could pull out the people who had the highest exposure, the longest duration of employment. That isn't the kind of nature we get. What we get here is something that kind of mimics really what you would see if you did a meta-analysis of a whole bunch of cohort studies and did the overall results and pulled them together. But still it provides very interesting stuff. One thing that is in here that wasn't in the previous studies of firefighters is mesothelioma, which has been too rare to look at in any one cohort study. And people might theorize that firefighters, because they're going into buildings where there was asbestos was used in insulation, that asbestos gets broken, open, it's not, it's actually in the air as a structure is going down. You might theorize that they have increased risk of mesothelioma, but previous cohort studies might see 0 or none, or maybe 1 or 2, even if they're a very big study for mesotheliomas. Here they see 17. And you can do basic analyses by age in this case. So for instance, one of the interesting results for us by age was an increased risk of prostate cancer among firefighters under the age of 50, which is, we might theorize might be related to the fact that they're all on rotating shifts. At least that's the pattern here in North America, and I've been told that's the pattern in the Nordic countries as well. And then mesothelioma, for instance, occurs primarily amongst older people when they're occupationally exposed. So it does provide interesting results. So what we're working on now at the Occupational Cancer Research Centre is taking a 1991 linkage that's been done with the 1991 census into both the National Mortality Database, which happened a while ago, and I know that Canada, for instance, has been involved in that. But the latest thing that's happened for this is that with additional funding from Health Canada, they've now linked that into all the Tumour registry data in the country, and as well as the tax data. And the tax data is there because Health Canada's interest is in air pollution, and they want to trace where people lived throughout their follow-up, and they can get their addresses every year from the tax data. Unfortunately, they won't allow us to access the tax data to identify their occupation from the tax data, because that would be great. But instead, what we have is their occupation in the 1991 census. And right now we have follow-up through 2003, but they're in the midst of extending that to 2008, which is a major increase for us. I'll talk about in minutes. Now, the occupation in the census is supposed to be the job or business in the week prior to the 1991 census. So there are set rules for the interpretation of what an occupation is in the census, which is useful. So for people who are interested in this, I think it's you can kind of see that there are very set rules for it. It may not be perfect, but it certainly does give us some decent information. And Stats Canada has done all the work of coding it into a very standard classification system. So what we start with is that the long form census, which unfortunately was axed, so the last long form would have been 2006 now, represents about 20% of the population. For this particular thing, they excluded people who were less than 25 years of age. So the census respondents that were sent for linkage were 25 years of age or older, and about 20% of those couldn't be linked to probabilistic record linkage that use a combination of name and age and location, geographic location. But about 80% of this population was linked, which is useful. And so these are the folks who were linked, about 2.7 million people, but not all of them were employed. That certainly includes a lot of folks who were either unemployed or were retired. And so what we have is, when you split off that 2.7, there's about 1.3 and a some and a bit, or 1.4 million men and women. And here you see how many working age men and women there are. 1.1 million men, 950,000 women. So this is the population that we have to work with for this thing. It certainly is, we can lament that it is not 15 million as the Nordic studies, but it still is a fairly substantial population to work with. The analyses that we've been doing have been using Cox proportional hazards modeling. This differs from what they've been using in the Nordic countries. So we get hazard ratios instead, but we should be getting relatively similar results, we hope. Our base models just include sex, age, and province. Registration does differ. Some of the rules do differ a bit by province. There's also other kind of geographic patterns that this helps somewhat to take care of. We do have stuff around socioeconomic status that's included in the census. So we have income and education. You do get things like parity, which is important, let's say, if we're to look at breast cancer or ovarian cancer, which is one of our things of interest. The census, unfortunately, does not include a lot of cancer risk factors like smoking, alcohol consumption, those kind of lifestyle factors that we would love to be able to take care of. We've done a number of pilot projects, and I'm just going to, so that I don't go too long, I'm just going to show you examples of those and, pretty quickly. But just to give you a flavor of things, all these results at this point are preliminary. We're probably going to be, I haven't even attempted to put in the very last analysis because I know we're going to be doing a few more changes. So we have, we've tried to look at firefighters. For comparison to the Nordic countries, we looked at lung cancer among welders. Ovarian cancer, we tried to look at ovarian cancer in different occupations to see if we saw anything interesting. Sinonasal cancer, and a project that didn't really work out, looking at laterality of upper limb melanomas, which was looked at in the States. But unfortunately, we discovered after we decided to look at this that many of our Tumour registries do not collect laterality. So this is an example of what we've got here. So for our firefighters, we had about 4,300 firefighters, 9,700 police. We thought we would do both as have a bit of a comparison, and we could look at some of the common cancers, but also testicular cancer. You can see that there was an increased risk of firefighters. This is something that's been seen, but the numbers are small, so this is not statistically significant. But still, we are able to get interesting results when we pull out groups of about this size, as long as we're in particularly some of the common cancers. Lung cancers among welders, there are 10,300 welders, or 10,300 lung cancers among home men in the cohort. There's about 12,900 welders, male welders in the cohort, and about 125 lung cancers among them. So that gives you an idea of the kind of size of group and the number of cancers that you get. So lung cancer is not a very difficult one for us to look at with, let's say, moderate-sized occupational groups. In our analyses, we kind of compared welders to other blue-collar workers. You can make either ways that you can try to adjust for things like socioeconomic status, since we don't have information on these other confounding variables, is you can either try to adjust for socioeconomic status, which I sometimes worry about a little bit in terms of maybe over-adjustment for occupational groups, or you can try to restrict your comparison, in which case you can look at a group like blue-collar workers. And what you see here, for instance, is that if you just adjust for age, sex, well, we don't have to adjust for sex, so just age and province, you see some pattern of increased risk among welders, kind of differentiates from different subsectors that we tried to look at. You can adjust for the other things. The risks go down to some extent, and then if you just compare to other blue-collar workers, you see quite a substantial decrease. So there's still some sign of an excess risk there, but not as much. So it gives us kind of a battery of different ways that we can look at things. Again, I would encourage you not to think about the specific results, but only the examples of the kind of things we can look at. One thing that is kind of very useful for us is the ability to look at women. There are many fewer studies of occupational cancer among women. So the fact that we have 950,000 working women is quite useful. We had a student last summer who was actually an oncologist in an oncology residency program, but her area of interest is ovarian cancer, so she looked at that. You can see that working and non-working women in this cohort are quite different in terms of age and peri, number of children. Less children, younger age, older age here, because it would include these non-working folks, but much higher parity as well. And so there was an attempt to kind of look across a lot of different groups. We didn't find a lot terribly exciting here, but still I think these analyses will be rerun when we go to the 2008 set of data that we have. But you can see that we can pull out a lot of different groups. Challenge is that even though we have 950,000 women, women in let's say blue-collar occupations are still a smaller fraction of those. We certainly got huge numbers of people in white-collar occupations or teachers and nurses, and probably less so in things like textile workers. This is just a little comparison we did looking at cancer among woodworkers, and it gives you an idea of the relative power, sadly, of the Nordic study versus our study. I think I mentioned earlier that sinonasal cancer is very rare. There are probably maybe 10 or 12 adenocarcinomas, which is the subtype we're interested in per year, maybe in Ontario. So here they're looking at all woodworkers, and you can see an increased risk for all sinonasal cancer with 355 cases among men and 10 cases among women. When they restrict to adenocarcinoma, the risk is much higher among men. They don't see any cases among women, but they have 122 cases. When we tried to look, we have 6 cases overall of all types of sinonasal cancer. So quickly we bounce against our limits here in terms of what we can do with very rare forms of cancer. These are some of the new analyses that we have up and coming. We want to be able to look at shift type using the Survey of Labor and Income Dynamics from 1993, kind of develop a job exposure matrix, or the ability to classify people on the basis of occupation and industry as to probability of different types of shift work. This is a model that has been used successfully in the Nordic countries and did show, for instance, patterns associated with breast cancer. We'd like to test that here and look at other types of cancers as well. We'd like to look at sedentary work and colorectal cancer. We'd like to look at agricultural workers and maybe look at geographic patterns, maybe down to a finer level in a future set of analyses, because we actually do have pesticide usage maps that we've developed through CAREX Canada. And in fact, we'd like to move from a model of looking at exposure using quantitative job exposure matrices with data from CAREX Canada using models that have been developed in Europe. So, and this will be kind of in parallel with what they're now moving towards in the Nordic studies, and in fact we're collaborating with them. Even though I would consider us a very junior partner, they're actually happy that there's any partner out there at all, because it's always been simply the Nordic countries, and at least we have more people than Iceland. We're also trying to look at some new methods for controlling for smoking and other potential confounders. And this is in collaboration with Rick Burnett, who's at Health Canada, who has a similar set of issues when it comes to trying to use the same data set for environmental exposures. And they're actually very happy to collaborate with us, and Rick is very, very good. So we're looking forward to doing that. And the idea here is that you model how well what happens with smoking, let's say smoking or alcohol consumption, when you have a model in that has occupation industry education and income, is there still the potential for confounding after all those things are in your model, and province, or have you kind of largely taken an age as well? I'm sorry. You're taking into account all those things. How much residual confounding is there? Do you need to have both income and education in there, or is one better than the other? So we'd like to look at that as a potential way to go. We want to do more comparisons with the Nordic countries. It could actually even at some point come to pooling data with the Nordic countries. But we use Cox modeling, and they use kind of an SIR approach, which is the kind of classic thing to do for surveillance. So we're going to try to do some comparisons just to see. We think we should come out to the same answers, but we're going to try to reanalyze our data using kind of really the approaches that they've been using in the Nordic countries. And actually, they're going to give us their code from their computer analyses, and we're going to try to run them here. And we're looking forward to rerunning our analyses with follow-up through 2008. For people who don't deal with cancer, cancer doesn't rise linearly. It rises, quite steeply with older ages. So this 5 years of additional follow-up that we're going to get is really going to substantially increase our power. And that's a very good thing. As you can see, we've had some challenges despite the size of our population. Now the limitations, and I'm almost done here. The limitations of this, I think one of our biggest limitations, as I've been repeating over and over again, are power. Specific issues might be women in blue-collar jobs, some specific industries in Ontario that we might like to look at. We might be actually quite challenged using this kind of an approach. Issues around potential confounding and assessing what those are. We're trying to address this as a confounder, but certainly this will be one of the primary limitations that anybody would bring forward in looking at our analyses. And the completeness and consistency of data across provinces is something that we do need to assess and look at. We certainly ran into that with laterality. Laterality is a weird thing. I should explain what that is and also what that project was. There was a thing that made it into like a big thing in the US press and here even about drivers having increased risk in their left arm. That there was an increased risk in the left arm people, but it wasn't an occupational study. It was just in the general population. Rates were somewhat higher on the left side, and they were saying that's because people aren't worried about sunscreen when they're driving. So we said, well, if this is real, then if you look at truck drivers and taxi drivers, we should see that much more clearly as a signal, and maybe that's a thing that's actually, we could be actionable in terms of prevention. We could recommend that professional drivers do apply sunscreen. Anyway, we kind of hit the wall on that one because not all provinces actually collect that level of information. They don't actually code left side versus right side, which is what the laterality thing is. We still might revisit that when we have more numbers, because a few of the provinces, I think, do collect it. And it'd be a very simple study, but a good example of one that could be a very quick answer and yet have good prevention uses to that kind of data. I'm just going to mention this quickly because I've been speaking too long. We're trying to look at an alternate method in order to deal with this thing of how do we actually look at groups in Ontario. And that is to kind of connect in. We have a $30,000 kind of small grant there from the WSIB, and I should mention that they've given us a much more substantial grant to look at the surveillance model that I just previously did. But we have a development grant to look at the linkage of workers' comp records with Ontario Tumour Registry records. And it would be a large Ontario-based cohort as opposed to a national cohort. The particular things is that it'd be skewed towards groups at higher risk for injury, because that's who gets time loss claims where they bother to add an occupation industry to the records. And it's a skewed sample of the labor force as well, people who tend to be younger and male. But the skewness may not necessarily be to our disadvantage in that those also are often people in occupations that have high risks of injuries, also might be people that might have a higher risk of exposure to carcinogens. Now, if we were to draw the previous model on there, we'd have 1991, and we're following everybody else forward. What happens here is that each year we'd be adding in another cohort of people and gradually building up our numbers over time. And what you see is that, and I kind of tried to do this, but time loss claims, you know, who knows what proportion of these records are going to be linkable. We hope a lot. But what you'd see over time is that we could end up with as many as over 2 million people in this cohort. So the same size as the national cohort, but only focused in on Ontario. Less office workers, more blue-collar workers, probably lots of healthcare workers, other groups that might have a chance of injury. So it's a kind of an interesting model. They've used it to look at asthma in Alberta, and it was quite successful. And our 2 million estimate is actually right in line with, I mean, considering they're much smaller, they actually still got very substantial numbers of people. At kind of our sister group there at EBC, they're looking at it as well, and they're doing some pilot work with looking at it for cancer. So this could be a very useful thing, not just for cancer, but if this model proves good, looking for other types of occupational disease as well. But it does have challenges, you know, and as well as advantages. It isn't, you know, national, although we could pool our data with others, but it does give us ability. Let's say we want to focus in on the auto industry. So it's a blue-collar group. It's here in the province. We will get much bigger numbers using this kind of model than we would with a national representative thing. So that skewness sometimes can work in our favor. But we also probably have some flexibility. Those of you who've worked with Statistics Canada know that they've got rules and they've got issues and they've got lots of limitations. And as much as I enjoy our, I think I've only got an acknowledgement left, I hope. As much as we enjoy working with the people from StatsCan, they're great collaborators, the fact is that everything has to be vetted once it goes, you know, before it can go out. They have like very strict rules about, you know, that sometimes make no sense to others of us in terms of rounding or small cell sizes, as though that could somehow threaten somebody's privacy when we're looking at a national sample. So we think we could actually have a lot more capabilities and speed. So as I mentioned, Ann Harris has been coordinating and leading this project. We have students such as Jill Hart and Lou Erickson who have worked on it, but in fact other staff members have contributed over time, and gradually a number of people are probably going to take on small projects here. I've talked about some of our collaborators. These are our Health Canada collaborators. I put Eero Pukula from the Finnish Tumour Registry, but there are actually many of the folks in NOCCA have been very generous in their time and willingness to provide us support. And of course our funders for the center, as well as the WSIB, which is funding our overall, kind of the core funding now for that project. So I'm going to stop there. Sorry if I've gone a bit long.
All right, thank you, Paul.